In this episode in our series of knee pain while running, we're going over runner's knee.
Now into myofascial release of the quad, there's many ways to do this, but in this case, with runner's knee, we want to work the quad closest to around the kneecap as we can. And for this, I'm going to place a broad contact. See the webbed contact I have? You can also do a thumb contact, some fingers, but for the most part, we want to make sure that we are getting into the areas where we feel any restrictions or gristliness or denser tissue within the quad. So I'm actually using my leg to press her leg backwards, because oftentimes patients don't want to do the knee bend for you, but this really helps get the tissues or the quad to pull past my hand or through my contact point. Now there is fascia, and there is fascia between muscles of the quad. The quad is obviously 4 muscles. That's what the definition of quad is. So I like to just kind of find between the areas too. There's different heads of the quad muscle there. So we kind of look and feel and see if we can get between those sections to make sure these areas are sliding well. There is one quad muscle which actually goes above the hip, and we can treat this from a sideline position as well. But we want to make sure, especially those 2 joint muscles like the rectus femoris, do slide amongst the other quad muscles. Now with this other type of quad myofascial release, we're going to use a lot more lotion, and we're going to slide a lot more. And oftentimes we use this to treat the muscle directly or to try to separate the fascia or the top layer of the, kind of just below the skin. If you imagine chicken breast, how it has that slime on it, this is what we're working on with this type of technique. Do a lot of passes and do them really long stroking fashion here. So you might need to reapply some lotion or oil. Next, we're going to do a bit of lotion on the bottom part of the kneecap, or just around what we say the patellar tendon. Now, the reason why this is important, and I know we covered this in the patellar tendon section, is that we need to actually treat the areas attaching to the kneecap, which is going to be the fascial areas from the sides, the patellar tendon on the bottom, which we're at now. We did the quad and the quad tendon earlier. Now, what I like to feel for is for areas of relatively increased density. And when you feel on the patellar tendon, you're going to feel that the whole thing is just really, really raily. It's like a rope. Now, what we're looking for is areas of relative increased density or firmness in relationship to areas on the patellar tendon as well. So let me say that one more time. It's a difference of density from the other section of the patellar tendon. You might find one area feels swollen or boggy. There's another area which might feel like it's just kind of gristly. These are what we're looking for, and we're taking really firm, long strokes throughout the patellar tendon, throughout the entire tendon, to really make it so we're making a difference here. Now, myofascial release of the hamstring group, I like to use a bit of lotion and kind of feel for the tendons. I like to go and kind of bow the tendon a little bit and then move her leg for her. So I'm actually, you can't see my hand in the camera, but I'm moving, extending her leg for her. And this is drawing some tissue or some tendons past, as well as the muscle when I'm higher here. So right now I'm on the lateral hamstring, which in this case we're going higher, so we're actually on the biceps femoris, and we're going in the long head here. There are 4 hamstrings, and there is only one which doesn't go past the hip. For this reason, I do like to have the hip bent in this position, or even higher. Sometimes I will actually bring them into more hip flexion or knee to chest when I'm working on them, but these are 2 joint muscles. Just remember that when you're working with 2 joint muscles, meaning muscles that cross 2 different joints, they have an effect on both joints, so we can't just ignore it and just go to the knee. So again, I'm doing long strokes here, just kind of looking for gristly spots, looking for restrictions or areas that are adhered, and I'm working on them and focusing on those areas specifically. Now, myofascial release of the popliteus muscle is kind of a hairy area. I wouldn't recommend people do it on their own at all. Even if you're a healthcare provider, you need to make sure that you know the vein, artery, nerve in the area. And this muscle is important because it attaches to the outer meniscus or the lateral meniscus. So it can affect some knee locking, unlocking issues, which can eventually become issues related to runner's knee. So this is on the outer portion of the knee, on the backside, below a bunch of muscles. So some of you might be thinking, I don't know if he's getting that deep. Well, I'm probably not. Realistically, I'm holding pressure and I'm moving some of the other muscles on top. So I'm trying to get relative slide again. Some of this is you won't get actual treatment on the tissue itself, but it doesn't mean you don't get increased slide. So I'm working all the way out into the lateral joint here. So what some of you might not realize is the gastrocnemius, or the larger calf muscles, the bigger ones, the higher up ones, the ones closer to the surface, actually do pass the knee. The soleus is an extremely important muscle, which is deep to that, to be able to generate power and drive when running as well. So the calf is really important. So I like to do myofascial release of the calf, the gastroc, which here I'll bend the knee a little bit more, and the soleus, which I don't really necessarily need to bend the knee, but I need to bend the ankle here. So I like to work it all the way up to mainly its what we call its musculotendinous junction. So there's one musculotendinous junction up at the top here, which for the gastrocnemius does go higher than the actual knee itself. So it attaches to the femur. Again, what we call this, again, the two joint muscles are extremely important. Not to say the soleus isn't, but the soleus is the musculotendinous junction we're looking for is more down to what you would call the Achilles tendon. So kind of like just above where my hand is now on the bottom hand. Spend a long time doing strokes in this. By the way, if you have been on an airplane, you need to make sure that you are not experiencing a deep vein thrombosis, or called a DVT. I cannot stress that enough, and I'm going to pause the video here because of that. We need to make sure that all calf pain is not a musculotendinous injury. Sometimes you can have a blood clot, and if you massage out a blood clot, you're going to die. Seriously, it will dislodge and go into your lungs and kill you. So make sure you have the correct diagnosis, and these are all instructionals mainly to show you what we do in the clinic here. Myofascial release of the external rotators, which can be the gemellus, the piriformis, some of the glute medius area I usually perform like this. I have to bring them into hip flexion, put some pressure on there, and really hold some good tension, and look for restrictions all along the way. So you can't see, but I'm actually rotating her hip as well, or her femur. And it's important to realize that these muscle groups are actually really important to not only externally rotate, because again, they're quote-unquote external rotators, but they actually limit how much internal rotation, which when you know anything about running injury, overuse type of mechanics, internal femoral rotation will create knee injuries. There is a cascade of this that I will do a video on eventually, and we definitely have a podcast on it, so p2sportscare.com/podcast. But what I like to look for, again, with this is that we're finding any areas of relative gristliness than other relative areas around it. So this will be tender on a lot of people anyways, so tenderness is not something I typically look for. I like to feel if there's any railiness of tissues amongst the other ones, which is relatively abnormal. So I usually spend about 30 seconds to a minute doing this. Remember earlier I said it's important to get rid of restrictions of the quad tendon, the patellar tendon, and the fascial attachments around the knee cap or the patella. This is what we're doing here. Look at her quad. Her quad is not contracted. I cannot stress this enough. If you do it with someone contracting their quad or with someone resisting you, you won't get movement around the cap. Now, it's important to realize with Chondromalacia Patella, the irritation they feel is under or deep to the cap. Do not grind the cap into the femur below it, because that is where the pain is coming from. But it doesn't mean you can't push it from side to side, up and down, and look for those gristly spots right around the edge of the bone. Okay, this is mainly up to the patient. It's up to tissue tolerance. How much can they physically tolerate before they stop you? There's no point in making them more and more irritated. But a lot of these tissue work techniques are minorly inducing some inflammatory process to stimulate repair. So let me say that again. We're actually going to get a little irritation later, but that does not mean it's an abnormal thing. I tell patients a lot of times, you will feel a little sore for about 24 hours, but that is completely normal. So again, look for the gristly spots here, kind of push the cap around. You see I'm just kind of kneading it away. Now, over the course of the next few demonstrations, we're actually going to do more of a rehab approach here. And I thought it'd be really productive to actually have Laura go through the stuff that I have not shown her before, but she's going to make some mistakes. So I'll try to make some corrections along the way as much as I can with the camera in my hand. But I think the process of learning how to recorrect and look for the things that are wrong in the movement patterns is super important. And I've had a lot of people ask me, can I do some videos where I'm actually correcting and cueing people through? So this is my first attempt at that. Enjoy. Now when we're teaching the hip hinging pattern for runner's knee, oftentimes we have to pattern it. And doing it with a band such as this is just a standard resistance band we're using. You want to hook it real low onto the hips right there, because when we're patterning this hip hinge or a deadlifting type of pattern in RDL, then we want to make sure it doesn't slide up her butt there and up onto her back. So go ahead and let's go into a hip hinge. So that's not it right there. So that is a squat. So
You said.
it's okay. So what we're going to do is we're going to show. I want you to press when you go backwards, like into a good morning. I want you to actually press your hips into the band. Good. And make sure your knee doesn't go beyond my hand right here. Go ahead and come back up. Let me switch hands so we have a good view here. So go ahead. Good. That's better. I'm going to shorten you up a little bit here, okay? And right there. So you really just go into, you can feel the hamstrings tighten. So I'll back up so you can see a little bit what we're getting now. Go ahead. Good. So right there. Straighten the knees slightly for me. Good. So now she's using the band to press her hips backwards and be able to get her weight posteriorly, or we're looking for that hip break. Go ahead and stand straight up again. So give me about 5, 6 of these, okay? So again, the reason why we do this is because a lot of people tend to shift their weight forward, and they're not aware that they have to actually actively drive their hips backwards. It's not just something that comes naturally. So this is a good exercise to help them pattern that. Again, they do mess this up sometimes, and she's going to show you a quad dominant movement where they basically shift onto their toes. Go ahead and show that for me. There you go. So they're trying to squat it. This is a very different feeling than you get if you're actually going to press it backwards with your weight. And obviously her torso will come forward slightly, more so than on a squat. Show us one more on a squat. So she's a lot more upright. Sometimes people don't feel comfortable getting their weight back like that. They're going to feel like they're going to fall backwards. So this is the active patterning of the hip hinge. Okay, so the Romanian deadlift, or the RDL, or the technically hip hinging pattern, we like to teach with a stick here. So Laura, why don't you put that stick on, so there's going to be a contact point in the back of your head, the mid-back, and the butt crease. And at any point during this movement, you should not move, you should not lose those contact points. She has the ponytail on, which sometimes isn't it's hard to get the right contact. There you go. Okay, so you're going to see those 3 contact points, okay? Nothing's moving there. So go ahead and push your hips back and get the weight onto the heels, just as you did with that active loading pattern one. And this looks pretty good. People who are pretty tight will feel the hamstrings tighten at some point, and that is what we're looking for to make sure they are feeling and getting the right hip hinging pattern. It's not uncommon for people to try to shy away from that, where they'll squat down similarly to with that active patterning that we saw. So Laura, give me one where you're squatting down. So they're trying to deload the backside there. Give me one more. So again, what I typically do to correct this is go ahead and go into that squatting pattern one more time and stay there at the bottom. So right there. So stay there. So we see that the contact point is still on the back side of the back, which is great. So at this point, I'll tell them, why don't you straighten your knees out a little bit, but keep everything else the same. Good. So right there, they'll start to feel the hamstrings straighten up a little bit, or actually we call this the stripper move sometimes, because basically the butt is moving up. And go ahead and stand up one more time. So we're going to do this in 2 parts. Go ahead and do the movement, squat down, because this is what sometimes they'll do. Okay, straighten the knees. Good. So now they're into that RDL pattern. So hopefully now they can find it on the way down. So go ahead and find that for me. Good. And if this really doesn't work, go ahead and come back up. I'll hold my hand right here and tell them that their knee should not touch my hand. A single leg Romanian deadlifting pattern, or a single leg RDL, or an SRDL, is basically a standing bird dog, which we already showed in a different video in this series. So go ahead and Laura, we're going to do I want you to put most of your weight onto, or all your weight onto one leg. The other leg is going to drive backwards with the heel. Straighten that leg, straighten that left leg. Good, drive with that heel. Now bring that right arm out. You're going to get your bicep onto your ear. And now crush that toothpaste. Now she's having some issues here. Drive that leg. Okay, so go ahead and come back up. So what we're going to do is actually we're going to leave the arm out of it and focus on just the leg drive. So go ahead and drive that heel. Now stay right there. So we're finding that she has a breaking point right here. So we really just want, straighten that leg, drive that heel straight through the wall. Good. So we want to make sure that all this is one straight line, just as in the bird dog. And she's doing better right now. Come back up. Give me that again. Let's not go as far down, okay? Heel drive. Good. So that's much better. Now make sure your belly button, and if you had a headlight on your pelvis, it'd be pointing straight down, okay? Come back up again one more time. So this time I want you to lead with the leg, okay? You're bending forward first. Lead with the leg. There you go. There you go. Let's go right there. Straighten that right leg, or bend that right leg a little bit. Give me a little bit of soft knees on that right leg, okay? Let's go right there, okay? I want you to make sure your belly button is pointed straight to the ground. Drive that heel. And now if you want to add the component, add that right arm. Reach up above the head, crush that toothpaste. Good, and then come back really slowly. It's going to be a great video. Okay, this time, once you get there, I want you to come all the way back down under control. Under control.
Okay.
It's going to be a 30-minute long video. Lead with the leg, good. Arm up, crush the toothpaste, get your composure. Okay, come back down. There you go. So just like the double leg RDL and the deadlifting, using that downside leg to bring yourself back up, okay? Nothing else changes except for on one leg. Give me one more for all your fans. Yeah, probably. Probably the fact that this is not a concise video, it's more of an educational one, and you're falling all over is going to be great. Heel drive, heel drive. Good, and then bring this one back up. Make it nice, make it nice. Good. Everyone give a round of applause. Everyone should give a comment below which rep was Laura's best.
You have to cut all the back.
Now, as fun as that was, making Laura do the single leg RDL, I think I needed to take over because I did have her do an airplane hip hinge here, and it was absolutely terrible. And there was no form I could show you, no video I can show you, which was great. So I took over and had her hold the camera. So notice that when I'm first going through the straight-legged, the single-legged one, I have a little bit more knee bend than Laura, which is what I would ideally want. I'm driving with the heel, and I have the hand crushing the toothpaste, and I'm straight as a board, like those old drinking birds back from the 80s. So that is the first thing. You have to come back with composure as well. So I'm straight again here, and coming back under composure. Next, we can add the rotational component, which is the airplane, or what we say some people like to think of banking. So I'm banking like an airplane, opening the hips towards the camera and the chest, and closing it down and bringing it back again. This all has to be under control. And if you're wondering why the heck are we doing this, is that so we're moving the hip into a sagittal plane motion right now, and now, oh, I lost my balance. Now when I'm returning here, this is a completely different plane of motion, which is important because the hip needs to be able to have lots of control in rotation, lateral motion, and forward backwards, because if you know the mechanics of how knee injuries happen with runners, we need the hip to work well. So we're not ignoring the knee, we're just emphasizing the hip. Okay, let's go over that mechanism of injury of how this happens again. I thought I'd draw it out for y'all. So this is the pelvis, here's the thigh or the femur, here's the knee, here's the lower leg, and here's the foot. Same thing here. We have the pelvis, femur, knee, lower leg or calf area in the foot. I know that's a terrible foot drawing, isn't it? But this is the mechanism of injury for running injuries that are quote-unquote overuse. If you did not actually
fall or get hit, these are the mechanism of injury, okay? So first we have, this is the pelvis drop forward, okay? If we're facing this way, the pelvis drops forward, which again, if we look at the spine, I guess I shouldn't have drawn it as high, the spine will turn into hyperextension, or you'll look like a sway back person, okay? Look around next time you run, you'll see these people do this and it'll look like their butt's sticking out, okay? Next, you'll see this femur rotate inward, okay? Inward, just like that. You'll see this spin like that as well. And then you'll see this foot start to cave inward. So this is looking from the side, okay? This is looking from head on. What we have is, again, this thing rotates forward, just like that. So it's like the pelvis drops forward. Sometimes we'll have a little bit of a hip drop as well. The knee starts to dive in. This starts to rotate inward, and the foot starts to cave. So when you see people with pancake feet, you have types of Achilles tendonitis, chronic tendinitises of the foot, plantar fasciitis, all of it happens from this mechanism of injury. And when you see things like, let's see, we're talking about runner's knee this time, or Chondromalacia Patella, also meniscal injuries, let's just say medial meniscus over here, this gets irritated. The IT band on this side gets irritated. Hamstring injuries, hamstrings go all the way up from the pelvis to the knee. They get injured. And we have things like FAI, or femoral acetabular impingement, right here. We have low back pain on this side because we have a sway back type of appearance. So I guess I should cross this off. It's a mechanism of injury for running injuries, okay? Although they're considered overuse. Now I'll put a reference on this so you guys can see that I'm not telling a lie with this. Sure, you can do treatments to like the tissue in here and here and here and here. Yeah, you can do that. When you actually have a tissue, and let's cross this thing off. Let's just say we have a muscle like this, and we have a tendon, which is like a wider, denser part, and then you have like a fray in here, or like a tear in the muscle. Sure, yeah, we got to deal with this. We have to get this thing to repair. That's why we'll do things like our tissue work, or we'll do our ultrasound. I guess this would be an ultrasound probe. You know, we do our ice and heat and all that stuff here, but it doesn't change this. It doesn't change these mechanics. So all of this has to change, and that's why I've suggested isolated within the joint things for runner's knee in this video, because we have to work with things like, actually in the case of runner's knee, it's not a tear, it's a degrade of the cartilage. But you still have to deal with this isolated part, but we need to deal with this. And that is why I've included so much rehab in these knee conditions for runners videos so far. If you haven't watched the other videos, you really, really need to, because I've given a very large comprehensive look at knee injuries, and you need to understand them and how they happen. Now when we're looking at that same type of mechanism I just drew, I'll try to simulate it on me. I know I got high shorts on here, but let's just say I'm dropping with the hip, okay? Let's look at this guy from the side. Let's put his leg up, or his arm up here maybe, so you can see him. Maybe he'll eat his arm. There you go, that works. Okay. Didn't work. Okay, we'll leave it right there. So say I'm pushing forward from this, so I turn into a sway back. Relatively, these things twist forward, and already demonstrating this, my back hurts actually. Because of the bony geometry in here, this will rotate in, okay? And from this side, it'll look kind of like this. This is actually better seen from a front side view, so I'll continue from the front side. Okay? Now that we already talked about this part, now we're talking about this cave right here, which you'll see the knee cap actually tends to look like it's coming inward. By the way, remember that this thing is actually floating here. So if you look on me, so I'm going to show internal femoral rotation, so relatively the knee combined goes in. Now look at the ankle, because I can't really show on this guy down here because he's not attached to anything, but look at my ankle. As I rotate this in, the ankle also moves, and you actually feel different structures of the foot start to react as well. So this is why that you can get foot ankle injuries from stuff happening all up here. And when you're in single leg stance like this, we're basically emphasizing this even more if your neuromuscular system does not have the capability of keeping position. Let's go through the cascade how we can actually change this from all happening. And it all starts from a standpoint of lower leg stiffness as well as neuromuscular control. Now, let's look at the ways we can actually work with decreasing neuromuscular fatigue or increasing our resistance to neuromuscular fatigue. Now, again, let me reiterate, the reason why we need to decrease our neuromuscular fatigue is because we need to make sure we keep proper form and so on. What eventually happens is as we start to fatigue, we load certain structures. Let's just say we have this tendon right here. Okay? The tendon normally is able to take a certain amount of load. Let's just say 100 newtons, something arbitrary. Okay? So when we start subjecting it to 100 newtons here, we're totally okay. We're good. Because it's used to repairing that amount of force and workload. Yet when we change this to like 200, all of a sudden it's not used to it anymore and it starts to wear away and degrade. And that's where we have our structural issues such as our degrading of cartilage, tendons, and muscles. Now, let's follow this thought process right here. So when we have increased neuromuscular fatigue or breakdown of form, we also have a decrease in lower leg stiffness. And lower leg stiffness is really, really important because decreasing lower leg stiffness also increases ground contact time. And this is where you basically have your foot on the ground longer rather than tapping. By the way, ground contact time also goes down with speed increasing as well. Now, ground contact time, the reason why all this is important is because we found that ground contact time, when it increases, it also increases your risk of running injuries. And that's not just saying knee injuries. We're talking about other types as well. Now you might be wondering, maybe I can just stretch and so on, and we found that flexibility does not increase neuromuscular control or our resistance to neuromuscular fatigue. So you have to keep all this in mind, okay? We're going to go through this one more time. We're trying to limit our ability to fatigue because we want to keep high lower leg stiffness to decrease contact time so we don't have as many injuries. Now you might be asking exactly how we decrease our ability or increase our resistance to this fatigue. A lot of this comes with a very well-designed plan of attack in regards to rehab and training, okay? And all the stuff that I showed today here is not everything, it's parts. We actually have another class, and I'm not saying I didn't want to include more for you guys, but it would realistically be like a 20 video series. So I just made a whole class on it as well. So we basically have to train ourselves to decrease or increase our ability to resist fatiguing. And I want you to look around next time you run. Just look and see. You'll see people degrading all over the place and looking like they're basically falling apart. Okay, so with runner's knee, the area in question is the knee cap right here, okay? If you have the person relaxed, have them relax their quad, and you can actually shake this thing and you can see the patella moving around like that. Below it is the patellar tendon. We did a video on patellar tendonitis, which is about here to here. The quad tendon is above it. There's the quad and the IT band. Let's spin her leg a little bit. And if we take it and grab it like this, we can see this structure start to define here. You trace it all the way down and it gets all the way down into the tibia or the shin bone right there. So with runner's knee, actually what we're looking at is the area underneath the cap. The pain is going to feel like it's underneath, and a lot of times when you take this and you press it down on the person, they're going to jump. Okay? And a lot of times if they contract their quad and you press in, they're going to jump as well. So go ahead and relax there. So what we're looking at in regards to mechanism of injury is actually we found that the femur turns, but the patella stays lateral, okay? Versus the idea that the patella or the kneecap actually goes lateral on its own. What controls the internal femoral rotation of the thigh is the muscles up into the hip and also having a stable core. So what happens here in a runner's knee is the kneecap remains stable again. This rotates outward, and then we start grinding this section underneath the cap onto the femur below it and actually has a groove that it sits in. So we're just grinding the heck out of the outer part right there, and it really pisses off the cartilage. So what we're looking at here, remember those mechanics we talked about earlier, this dropping forward, this spinning this way, this caving in, and so on, and we have all this stuff going on. Now, let's put some of this anatomy in. Let's just say we're looking at the rectus femoris, which is one of the quad muscles. It's the top one. It goes from the hip, actually, sorry, from the pelvis, and I'll spin this guy so you can see, from the pelvis down into the kneecap. So it attaches right into there. Now, let's just imagine from this point forward that actually my fist is the kneecap, okay? Because I want to show you that, and I'm going to show you, spin the femur underneath it, kind of how it happens when you're degrading away. Look at how it doesn't matter. It doesn't matter what this femur does underneath. My patella or my fist has the ability to stay in the exact same spot. Now, the reason why that's important is because look at this kneecap here. This kneecap has the ability to move. It's a floating bone. It's a sesamoid. It can move around, but relatively to this thing spinning underneath it. Look how it shifts right there. Okay? What we've learned in the past was that this kneecap was sliding to the side, so we say it was laterally tracking. But again, that MRI study showed us that relatively the femur moves and this kneecap stays right there. So what happens is the amount of force which is supposed to go through this side and is supposed to disperse it really, really nicely, it's actually going to be driving on the outer part. So we have 100% of the load driving down the outer part here, degrading that cartilage away and softening it. That's why they call it Chondromalacia Patella, because it's a cartilage softening. That's literally what it means. Rather than having it sit right in the middle, which would then allow both sides to take some of the load that you have when you're running, landing, jumping on it. So if you want the reference to this, I will include this. It'll be on the link to my main article, which will then have all the references on it. I'm not going to put all of them on the YouTube thing. I'll have them actually when you go through and read the article. So read the article. I'm going to say it in a little bit different way, and we're going to have this video embedded right there in case that's where you're watching it as well. Make sure to share this with your friends, and if you want to, if you have a blog, share it on your blog. I will show exactly how to embed it, because I think the more people we educate about this, the less running injuries, overuse injuries we're going to have, because these are totally preventable. If you want to learn how to actually prevent it, we have a class we're going to put on, and this is how we rehab in here, so you can actually learn what the experts do, or hopefully you consider me an expert, what we do to decrease the possibility of running injuries. Take care, guys. Talk to you soon.